My name is Vanessa Cullins. I am trained as an obstetrician gynecologist, but I'm strictly an administrator now and have been strictly an administrator since 1998. I'm Vice President for Medical Affairs for Planned Parenthood Federation of America, and I've been at that position since 2001. The areas that I'm over are clinical services, which is responsible for the Planned Parenthood medical standards and guidelines, which are the rules of the road in terms of medical service delivery. Another department that I'm over is research and also special projects. Planned Parenthood Federation of America is over 100 years old, and it consists of about 85 affiliates that are located all across the country. We have at least one affiliate in every state, and all medical health care is provided at the level of affiliates. Medical services are not provided at the national office, which is where I actually work. In terms of disclosures, as it relates to cervical cancer prevention, I have really nothing to disclose. I do have to disclose that Planned Parenthood Federation of America, through the Senior Medical Director, Dr. Aslesha Patel, is the recipient of a Merck investigator-initiated study, which is entitled Staying on Track, and it's basically about increasing the completion rate for the HPV vaccine series, especially in the older age groups. And by older age groups, you of course know I'm talking about those that are not covered by vaccines for children, those folks that are 19 to 26. All right, about Planned Parenthood and cervical cancer prevention, because this is really what I was asked to talk about. We, as I stated before, have more than 800 healthcare centers, and in 2009, we saw approximately 2.7 million female clients, 29,000 HPV vaccine clients, as you can see, 900, almost a million Pap tests. There were 13,000 referrals for abnormal Pap tests, yet we do have some affiliates that do provide management, diagnosis, and management for abnormal Paps in the form of colposcopy, so about 50,000 colposcopy procedures, about 2,700 lead procedures, 2,000 cryotherapy procedures. So as you can see, we are very much involved in the provision of cervical cancer prevention and screening services. And we primarily serve low-income, uninsured, and underinsured men, women, and teens. In fact, the total number of clients that we served in 2009 was well over 3 million when you take into account men. We are in a very unique window in U.S. history, as Vanessa and others have mentioned. If healthcare reform is implemented with a focus on preventive health care and on outcomes, then we are in a situation where we can begin to fix our very fragmented healthcare system. I'm going to talk a little bit about cervical cancer in general from a global perspective. We've already heard that in the United States there are approximately 11,000 new cases of cervical cancer that is diagnosed each and every year, and about 4,000 deaths. And that's, of course, what we want to eventually eradicate. Worldwide, cervical cancer is the 5th leading cause of cancer deaths, and at least 360,000 new cases of cervical cancer are expected annually, and it's estimated that almost 200,000 women die each and every year. In developed countries, of which the United States is considered, I say considered, a developed country, reductions in cervical cancer morbidity and mortality are a direct result of organized cytologic screening programs that result in widespread cytological screening and diagnostic biopsies followed by treatment of cervical cancer precursors. And we've already heard people discuss the fact that our problems are in widespread accessibility to the services that we already know work in terms of cervical cancer prevention. In Finland, A national screening program to prevent cervical cancer, which was begun in the 1950s, has resulted in cervical cancer rates that are now among the lowest in the world. Age-adjusted incidences of 4 per 100,000 women years, and a mortality rate of 1 per 100,000 women years. And this represents a 80% reduction in cervical cancer burden since the 1960s. Now compare this to the overall age-adjusted incidence rates of 9.7 for the United States from 1995 through 2004, and with rates as high as 15.3 among Hispanics and 14.4 among non-Hispanic blacks, with mortality rates that vary among 3 to 4.5 per 100,000 women. Service delivery challenges. Now, the service delivery challenges that most of us experience in this country are the result of our fragmented healthcare system. Tamika was indeed blessed in that once she was informed of her diagnosis, she was immediately seen by an oncologist who was able to do the rest of the diagnostic evaluation and to provide the treatment that she needed in order to be here today. Now, Dr. Casey mentioned a huge challenge within our system because of the fragmented nature of our system. And that is that there may be the ability through the federally qualified health centers to perform the cervical cancer screening, yet if you run into an abnormal Pap test, once you get to the stage of colposcopy and the need for biopsy, things that we said are critical to an organized screening program, those services will not be paid for, and a person who has no health insurance would be expected to come out of pocket with this very expensive service. However, we know that depending upon the program, in some situations, those biopsies and the colposcopy might be paid for through some of the Title X programs. But again, it's patchy as to whether or not a Title X program would be in a situation to be able to provide those services at low cost or no cost, but you do have some that do. And I'm sure there are other programs across the country where there is the possibility that this diagnostic and management services would be provided, but there are not connections and there are not enough of these particular programs. The defragmentation that we currently have within our healthcare center really requires the development of a seamless network of providers so that Americans can receive comprehensive care. And this also was alluded to in other people's talks and discussions. I want to give you a few real stories that I was fortunate enough to pull from, because Planned Parenthood now has a bank of stories from real women who are standing with Planned Parenthood and want to really prevent the attempts of defunding our particular services. One, a woman from Johnson, Iowa. I first started going to Planned Parenthood in college when I decided to start taking birth control. They answered all my questions because I was in college and not working. I was able to pay what you can for my pills. Years later, when I was 25, I had an abnormal Pap smear. My doctor sent me to a local OBGYN. The OBGYN took one look at me and told me I had HPV, that I was going to get cervical cancer before I was 30, that I wouldn't be able to have kids, and that I was having too much sex. Well, she goes on to say that she finally went back to her Planned Parenthood center and kind of learned the truth about HPV and cervical cancer prevention. And I bring this up to really say that providers need to be well trained, they need to be well informed, and that those in need of affordable birth control and also cervical cancer screening and other preventive services come from all walks of life and sometimes may be surprising to you as to who is really accessing services because they do not have seamless insurance and insurability for prevention services. One other quick example. My husband and I arrived in Washington, D.C. in 1995. He was doing an unpaid internship at a federal agency for his last semester of law school. We had no income and no insurance. I went to Planned Parenthood on 16th Street. They did a pap smear and discovered I had HPV that required immediate treatment to remove the cancerous cells. Well, she went on to be fine after she received appropriate treatment. Very quickly, I'm going to go through the rest of these slides because I need to paint a picture. I know our time is short, but I need to paint a picture that I think is going to be very important in terms of determining what our policy focus should be and what our priorities should be. This is actually chlamydia, but the same pattern is present for cervical cancer, HIV, and gonorrhea. And what I want to point out to you are the dark red areas, especially in the Southeast, in those Bible Belt states that are so adamant about states' rights. However, they don't have adequate infrastructure in order to provide decent health care for all of their citizens when you compare them to other states. I'm going to skip this slide, but it's a special program that Planned Parenthood is going to be putting in place over time with affiliates that are located in the South in order to reduce some of these health disparities. And then I'm going to leave you with some what I think are important concepts from a public health standpoint that are important in terms of policy development. We heard before, it's most important to access those who have never been screened or who have been sporadically screened or who are immunocompromised. Cervical cancer screening must continue along with HPV vaccination. U.S. providers must follow ASCCP guidelines for cervical cancer screening and abnormalities. U.S. labs must use the Bethesda system for terminology. It's the only way that we can communicate with each other as healthcare providers and be on the same page as it relates to how to really manage disease. Quality assurance and improvement activities are critical, and you heard that this is part of the plan as it relates to the Affordable Health Care Act, yet we need to be in the room and talk about the different ratios and indicators that need to be looked at across the board across all providers so that comparisons can be apples to apples as opposed to apples to oranges. And in terms of those indicators, they will really be important in terms of pay for performance. We need to be part of the development of the meaningful indicators for quality. And of course, the electronic health records and HIT efforts are going to be critical for us to be a part of, so that we're able to measure progress along the continuum of eradicating cervical cancer. We talked about rational allocation of healthcare resources. Rational implementation has to occur with consistent interpretation and enforcement of regulations. I mean, a prime example of where you have different enforcement of regulations is in federal programs such as Title X, where you have some parts of the country where, I'm getting ready to sit down, some parts of the country, there's a lot to talk about, but some parts of the country that are able to really follow the ASCCP guidelines and others can't because they're stuck in the past. And with that, I'm going to stop and thank you all very, very much. I'm sorry.